So positive Rovsing sign. Remember that ectopic pregnancy can also present like that, but they sometimes trick you by giving these sign and symptom and mention a history of pregnancy in the patient. So be careful while selecting the correct option for such kind of scenarios. Other signs that can be present in the appendicitis that is just for the knowledge are Dunphy sign, obturated sign, and Iliopsoas sign. Dunphy sign is pain on cuffing, obturated sign is pain on the internal rotation of the hip, and Iliopsoas sign is pain on extension of the right hip. For colorectal carcinoma, old age followed by family history are the more important risk factor. For urinary bladder, smoking is the most important risk factor. Now, let's see who answered this scenario. A patient with right upper quadrant pain that radiates to the shoulder found to have gallstones. He is vitally stable. What should be done?
Reassure.
Reassure.
It's not an incidental finding. I think it's symptomatic. So
Yes.
maybe an elective procedure to remove the gallstones.
So let me give you options. The patient here is in pain, so you cannot reassure a patient who is in pain. The management of asymptomatic gallstone is reassurance. Now, do we need to do lab cholecystectomy within 1 week, or we can opt for elective cholecystectomy, lab cholecystectomy?
Elective cholecystectomy.
Yes, because it's gallstones and there is no signs of cholecystitis, such as vomiting, nausea, WBC high, CRP high. In case of cholecystitis, we need to perform lab chole within 1 week. So in this case, we can do elective laparoscopic cholecystectomy.
So what will we do about the pain? Patient will be given pain. Killers
Yeah,
or
analgesics for temporary relief, we can give analgesics
analgesics. Yeah.
until elective. Basically, this is a case of biliary colic.
Mm-hmm.
Whenever the gallstone is stuck in the neck of the gallbladder, then it can lead to pain that is relieved when the stone is dislodged from the neck of the gallbladder. This is basically biliary colic, you can say.
Yeah.
In biliary colic, there will be only pain, while in cholecystitis, there will be fever, raised WBC, CRP, vomiting, etc. As there are symptoms, so reassurance is wrong, as he is vitally stable and no sign of perforation, so emergency laparotomy is wrong. Again, a scenario: old age plus anemia plus bleeding per rectum plus weight loss plus left lower abdominal mass or pain. In the scenario that we discussed in the start, scenario, old age and left lower pain while only favoring and bleeding per rectum or favoring colorectal carcinoma. But weight loss and anemia or abdominal mass was not there. Old age plus anemia plus weight loss and right lower quadrant pain, then it is cecal carcinoma. So colorectal carcinoma can be right-sided or it can be left-sided. So if the patient with all the symptoms such as weight loss, anemia, and left lower quadrant pain, then it is sigmoid carcinoma. Most likely sigmoid colon is involved. The same patient present to you with right-sided pain or mass weight loss anemia, then it is cecal carcinoma. Next topic is acute mesenteric ischemia and ischemic colitis that we discussed already. Now answer this scenario. An old patient presented with 2 hours severe and persistent abdominal pain of acute onset. There is abdominal distension, general tenderness, and absent bowel sounds. Venous blood gas shows lactate of 6. Is it ischemic colitis or acute mesenteric ischemia? ECG show atrial fibrillation as well. What is the diagnosis?
Acute mesenteric colitis.
Acute mesenteric?
Colitis.
Yes, acute mesenteric colitis or acute mesenteric ischemia, because the patient is having atrial fibrillation. So atrial fibrillation can lead to acute mesenteric ischemia. The other hint for in this scenario was lactate normal or high, because the blood supply or the oxygen supply to the gut is blocked. So the venous blood will have high lactate levels, because the oxygen that is supplied to the tissues, they convert lactate into acetate or acetyl coenzyme A, and then ATPs are generated through Krebs cycle. High lactate in venous blood plus a history of atrial fibrillation and abdominal pain and distension, your diagnosis will be acute mesenteric ischemia. Yes, acute mesenteric ischemia. An old patient with heart failure diabetes presents with complaint of 16 hours of abdominal pain that has begun at the lower left abdominal quadrant. The pain is gradual in onset, abdominal tenderness, and rectal examination also shows blood. So patient with a history of heart failure present to you with abdominal pain and bleeding per rectum. What is your diagnosis? Anyone?
Is this diverticulitis or?
The history of heart failure is important.
Mhm.
What can heart failure causes? Heart failure can cause low blood pressure or decrease supply of blood to the gut.
So
Ischemic colitis.
Yes. Yes, the other symptoms were favoring bleeding diverticulitis as left lower abdominal pain and examination. There is rectal examination shows blood. Yes, that can be right, but in this scenario, history of heart failure is important.
I think I'd seen this question on Plabable yesterday. I think it's a very similar question.
Okay, so what was the answer of that question?
I think it was ischemia. I think I'd gotten it wrong, and then I'd read on what the explanation was.
Okay, I think next time you won't got it wrong.
Hopefully.
History of heart failure, history of MI, both of them. A patient with a history of heart failure or MI present to you with abdominal pain and rectal bleeding, then it is most likely ischemic colitis. This is usually a hint towards ischemic colitis. While in case of bleeding diverticulitis, all the symptoms will be same. There will be no history of heart failure. They will usually give you a history of uh, taking meat only in the diet, or canned meat, or canned food. These are small hints they usually give in the exam. So ischemic colitis is the diagnosis. Now remember that whenever a patient develops ischemia, the most common side are splenic flexures, that is blood on the right side, and rectosigmoid. Both of these areas, these are called watershed areas. They have a very few collateral blood supply. So that's why whenever ischemia develop, or whenever there is decreased blood flow to the gut, rectosigmoid and splenic flexures are the most commonly affected locations. So there was a question in the exam in 2020, I guess, that they asked about the location of the symptoms. So if splenic fracture is given, then you can say that ischemic colitis of the splenic fractures, or rectosigmoid can also be a right option, because these are weak spots or watershed areas due to low number of collateral blood vessels. A 60-year-old man present complaint of severe abdominal pain and bloody stools. The pain is cramp-like and is of gradual onset. He had MI 2 days ago. Again, a history of MI is given, heart failure or MI. He also takes azathioprine for Crohn's disease. So here is a distractor as well, that they mention that the patient is also suffering from Crohn's disease, for which he is taking azathioprine. So this is a distractor here. History of MI, it points towards ischemic colitis. Gradual onset pain, bloody stools plus MI, most likely ischemic colitis. While acute flare of Crohn's disease or ulcerative colitis, they will mention 6 to 7 episodes of diarrhea, CRP high, ESR high, temperature high, fever, and heart rate more than 90. Plus, there will be no history of MI if they want to choose you acute flare of Crohn's disease or ulcerative colitis. So keep an eye on distractors as well. A child with fluid-filled mass on the midline of his neck below the hyoid bone. It is non-tender and it moves upward and on tongue protrusion. What is your diagnosis? It moves upward on tongue protrusion and on swallowing. Which which is the swelling which moves on tongue protrusion?
Branchial cyst or thyroglossal cyst?
Give me one answer. Branchial or
Thyroglossal.
Thyroglossal cyst, I think.
yes. Midline neck swellings are thyroglossal cyst and thyroid. Thyroid swelling does not move on tongue protrusion. Thyroid swelling only move on swallowing, while thyroglossal cyst moves on tongue protrusion. Branchial cyst and cystic hygroma are lateral neck swellings. Again, the most appropriate investigation is ultrasound and not FNSE. Like in fibroadenoma, the initial investigation will be ultrasound. Similarly, in this case, thyroglossal cyst, the initial investigation will be ultrasound and then FNSE. In the majority of cases, ultrasound alone is sufficient to make the diagnosis. Now, what is the answer of the scenario written in the key number 62? Offensive yellow discharge from an area near the nipple, plus history of abscess near this area that was surgically treated.
Paget disease.
Paget disease, one answer. Anyone else would like to answer this one?
Ductal papilloma.
Ductal papilloma. Anyone else?
There is a history of abscess that was surgically treated. I don't know, does this point towards a fistula? Because those are very common after drainage of an abscess. I'm not sure, just thinking out loud.
Yeah, it's more
Mm.
like ductal fistula. Yeah.
Offensive yellow discharge. Just first focus on the first line. Offensive yellow discharge from an area near the nipple.
So it's ductectasia or what?
No, it's not
Area near the
ductal.
nipple, it means the discharge should come out from the nipple and not from an. Yes, yes.
Periductal mastitis.
In periductal mastitis, is there any discharge?
No.
Yes, sir. In
Yes.
periductal mastitis, there is
In
discharge.
In periductal mastitis, there is discharge, but that discharge is from the nipples and not from an area near the nipple.
Near the nipple.
Okay.
It's something the duct papilloma or duct
Yes,
fistula.
abnormal. It is an abnormal communication. Normally, the discharge should come out from the nipple, but it is not coming out from the nipple. It means an abnormal communication is formed between the inside and outside of the breast. So
So
what is
that's
an
a
abnormal?
fistula.
Yes, that's a fistula. What is the cause of this fistula? The abscess
Abscess.
that she previously had.
Mhm.
So what is in duct papilloma?
In duct papilloma is common in young female, and there is a discharge from the nipple with no history of abscess
Okay.
or anything like that. And in duct ectasia, there should be a greenish discharge or brown discharge from the nipple. Again, the discharge is from the nipple and not in an area near the nipple. Plus, there will be no history of abscess.
I think I'd seen a question that said like a creamy, frothy discharge. And then I remember getting the question wrong, and then it was duct ectasia. So I believe it's not always a greenish discharge, but it's foul
Yes,
smelling or
yes,
It can be
that's what.
brownish as well. Greenish or brownish.
Yes, that's right. Whenever you get a question wrong like this, that in Plab piece that it was written that there should be a greenish discharge, but while doing the
Mhm.
question, there was creamy discharge. You should look for the other hints that are given in the Plabable question,
right.
and also try to share those questions by taking a snap on the group,
Okay, for sure.
because this way you will all of you can remember the distractors and how to differentiate the different questions in the exam.
Right.
Can you tell us about duct ectasia?
Duct ectasia is usually common in females uh, who are, you can say that, um, near to their menopause, above 45 years old. A discharge from the nipple in a female who is above 45 years with no other symptoms of malignancy such as weight loss or lymphadenopathy, then it is most likely ductectasia.
Okay, sir.
Dr. Shafraz, I would like you to take the snap of that MCQ in which a creamy
Yeah.
discharge was mentioned and it was ductectasia in the end.
Sure. Yeah, I did it yesterday. I was doing breast surgery. I think I'd seen it there. I'll go through it and I'll send you a snapshot on the group.
Okay, thank you. So offensive yellow discharge from an area near the nipple and history of abscess, fistula. Now this is an easy one, so we'll skip it because we have done it many times. Next one is also. Now, an old age patient with ear pain plus painful swallowing plus a lesion ulcer on the mouth at the back of the tongue plus palpable non-tender cervical lymph nodes. What is the diagnosis? This is basically a question from ENT, ear, nose, and throat. But still, we'll do it here. Old age, earache. So, is it a nasopharyngeal carcinoma or oropharyngeal carcinoma?
Nasopharyngeal.
There's an ulcer on the mouth at
Oh,
the
it's yeah,
base.
Oropharyngeal.
Yes,
oropharyngeal.
oropharyngeal.
Yeah.
Remember that in nasopharynx, eustachian tube opens in the nasopharynx. Eustachian tube that start from the middle ear, or there's the communication between the middle ear and nasopharynx is through eustachian tube. So for the diagnosis of nasopharyngeal carcinoma, there will be symptoms related to middle ear, such as conductive hearing loss or otitis media, or blocked nose. So yes, it's oropharyngeal carcinoma, lump or ulcer in the mouth or throat, referred ortalgia, ear pain, persistent sore throat and painful swelling, and presents in old and smoker males. Nasopharyngeal carcinoma, there will be swollen cervical lymph nodes that can also be present in oropharyngeal carcinoma because the area of drainage is same. The lymphatics of both nasopharynx and oropharynx both are drained in the cervical lymph nodes, so there will be cervical lymphadenopathy in both cases. The only difference is that there will be signs of eustachian tube obstruction such as otitis media, epistaxis, recurrent nose bleeds, and nasal obstruction as well. And also conductive hearing loss, tinnitus. Risk factors are also different. Epstein-Barr virus and alcohol. Alcohol is a risk factor for nasopharyngeal carcinoma. Epstein-Barr virus is a risk factor for two types of cancers. One is Hodgkin lymphoma and other is nasopharyngeal carcinoma. Tonsillar carcinoma will present to you with signs and symptoms of oropharyngeal carcinoma because tonsils are present on the oropharynx. Basically, this is a type of oropharyngeal carcinoma. How to differentiate peritonsillar abscess or quinsy from all these things or from tonsillar carcinoma? In peritonsillar abscess or quinsy, there will be dribbling of saliva and hot potato voice and evolver deviation and red and inflamed bulge or swelling above and lateral to a tonsils. Plummer-Wilson syndrome are also done. Management of anal fissure is also done. Now, if a patient present to you with and if the patient is not breathing and you have tried to intubate and the intubation is failed, if you are unable to intubate a patient, then you need to perform cricothyroidotomy. What is cricothyroidotomy? Cricothyroidotomy is basically an incision that is given in the cricothyroid membrane. Intestinal obstruction, we have discussed it along with paralytic ileus, that the patient will present to you with abdominal pain, distension, nausea, vomiting, constipation, and hyperactive bowel sounds. Initial investigation will be abdominal X-ray direct and urgent referral to surgical ward. They will decide that how to manage a patient of intestinal obstruction. Now, answer me this question and then we'll end our session here. What is the answer of this question? Key number 69. Can anyone answer this?
This is hepatic carcinoma or
Which carcinoma?
hepatic carcinoma.
It's acute biliary cirrhosis.
Back pain, weight loss, history of smoking alcohol, obstructive jaundice. What are the two most important causes of obstructive jaundice in surgery? What are the two most important surgical causes of jaundice?
Pancreatitis, chronic pancreatitis.
Pancreatic cancer.
Chronic pancreatitis or pancreatic carcinoma?
Carcinoma, sorry. Carcinoma.
Carcinoma because of the weight
Yes.
loss.
Weight loss,
Weight
pancreatic.
loss and yes, weight loss, and there is also obstructive jaundice. Remember that pancreatic carcinoma can compress the common bile duct, so it can lead to obstructive jaundice. Common bile duct stones can lead to obstructive jaundice as well. But in this scenario, history of smoking alcohol and weight loss favors the pancreatic carcinoma. Signs of obstructive jaundice include conjugated increased conjugated bilirubin, pale stool, dark urine, and pruritus. Abnormal LFTs, high blood glucose, palpable gallbladder. What is this sign? A palpable gallbladder. What is this sign called? What is the name of this sign? A palpable gallbladder in a patient with jaundice. This is called Corvisor sign.
Oh, yes, yes.
Corvisor sign or Corvisor law. A palpable gallbladder in a patient with jaundice. The cause is more likely a pancreatic malignancy and not common bile duct stone. This is called Corvisor law or Corvisor sign, that a palpable gallbladder in a patient with jaundice is always caused by a pancreatic malignancy and not by stones. Carcinoma of head of pancreas. So chronic alcohol intake can lead to chronic pancreatitis, which is a risk factor for pancreatic carcinoma. We'll end our session here. Other topics we'll discuss tomorrow. And as far as your mock test is concerned, kindly let me know that you want to give a mock test of 25 MCQs from each chapter, or you will prefer 50 MCQs from each chapter.
I think 50 from
50
each. is better.
MCQs for me.
Each.
That's good.
So
So tomorrow we'll finish surgery, and on Saturday we'll have our mock exam. 50 MCQs from GIT and 50 MCQs from general surgery. Kindly do practice them from Plabable as well as read them from Plab keys.
okay. So what topic are we going to start after this? Because neurologies, cardio, endo, and pediatrics, they are very long.
We can vote on that which topic should be started in the next. We can have a voting in the group, on the WhatsApp group.
Okay, that's fine. Yeah, because if for example, if somebody cancel the seat, so
Yes, there was some people who were canceling the seat in Feb UK, so you need to keep checking the website, because
yes, but
the people from Pakistan who have booked Feb Plab 1, they are not getting the visas,
yeah,
so they
yeah,
are canceling their exam.
yes, I heard it, and yeah, but then the preparation time is very less now. That's the
Okay,
okay. Thank you.
okay then.
Thank you much. Goodbye.
Sir.
Goodbye. Take care. Allah Hafiz. Good night.